Good evening, everybody, and welcome to BrisScience for October 2020. If you are just joining us for the first time, particularly warm welcome. BrisScience is the University of Queensland's free public lecture series on science, where we bring not just the best scientists, but also the best communicators to share their research and their passions with Brisbane, and now the whole world, in fact, because we are online, at least for now. I'm your MC for this evening, Joel Gilmore. I'd like to start by acknowledging the traditional owners of the lands, the many lands, which we're meeting on tonight, and pay my respect to elders both past and present. I'd also like to acknowledge those whose ongoing efforts to protect and promote Aboriginal and Torres Strait Islander culture leaves a lasting legacy for future elders and leaders. Tonight, we are, of course, online, and they'll be very pertinent given the subject of our lecture tonight. But that means that we'll be taking questions through the Q&A function. So if you look down the bottom of your Zoom window, depending on what platform you're in, there'll be a little Q&A section there where you can ask your questions. And at the end of the talk, I will go through as many of those as we can. There is also a chat function if you want to talk directly to the organisers about anything. But for the questions, if you could pop them in Q&A, that would be fantastic. And at the very end of the talk, there will be a little survey to get some feedback, so stick around after you log out for that. Okay, so tonight, as I mentioned, in case you haven't been paying attention, there is a small pandemic going on. And while it has been disruptive, this is of course not the first time that we've had to deal with something like this. And about 100 years ago, the Spanish flu, a name that Donald Trump would have loved, swept the world. And since those who cannot learn from history are doomed to repeat it, tonight I'm very excited to introduce one of the top researchers in viral diseases, Dr. Kirsty Short. And Kirsty is the head of the Viral Pathogenesis Lab at the University of Queensland School of Chemistry and Molecular Biosciences, where she studies, amongst other things, emerging viral infections and novel treatments. So tonight, to give us a little bit more on background of the history of those plagues and broader viral research, could you please put your virtual hands together for Dr. Kirsty Short?
Thank you very much. All right, so let me work out how to share screen. This is always the challenge of a Zoom meeting. Okay, first things first, can everyone see and hear me?
Yes,
okay. Okay, well, otherwise it's just going to be you and me, Joel, talking. So
I'm fine with that.
Okay, so I'm delighted to be here tonight to really talk to you a little bit about what we've experienced in the past with viral pandemics, and in particular to provide you with a little bit of a compare and contrast between the 1918 so-called Spanish flu and our current COVID-19 pandemic. But I want to, whilst showing you a lot of the things that are similar, leave you with a little bit of hope as to why things now are so much better and why essentially science has meant that we're in such a much stronger position than we were, say, 100 years ago. So just to begin, I want to remind people that this is not our first, nor is it our worst pandemic. And this is a nice graphic of basically the various pandemics that humans have experienced over time and their relative significance in terms of mortality. Now, I have to confess this is a little bit out of date when this was made. When this was made, COVID-19 deaths were sitting here. Now, unfortunately, COVID-19 deaths are sitting here. So that tells you how fast this pandemic is moving. But it is still nothing compared to the so-called Black Death or the bubonic plague, smallpox or Spanish flu, or even HIV/AIDS. So yes, this pandemic is bad and it's affecting a lot of us, all of us, very seriously. But it is not the first pandemic we've experienced. It is not the worst pandemic we have experienced. And unfortunately, it will not be the last pandemic that we experience. So let's talk a little bit about the origins of COVID-19. Really, whilst most people were sort of celebrating the new year, I remember very distinctly waking up early January, and the first thing I was doing was checking my email, because as an infectious disease nerd, you can actually sign up to these infectious disease outbreak alerts. And basically they send you an email almost every day about random outbreaks of infectious disease around the world. And there'd been reports just towards the end of December coming up on this email alert about this strange new pneumonia cases that were emerging in the city of Wuhan in Hubei province in China. And they seem to be centered around this seafood market. Now, what was very interesting was that on the 30th of December, this email alert suggested that this was very reminiscent of the original SARS coronavirus outbreak, which was already a little bit of alarm bells for those of us in the field that perhaps we had something of significance here. Now, even though these initial clusters were associated with that seafood market, what we actually know now is that this virus emerged long before it started being detected in the end of December, start of January in the seafood market. And there's suggestions that the first cases could be traced back to November, even as early as October. And although this may seem really hard to understand, what you've got to remember is this is a respiratory illness that was emerging in the elderly in China in the middle of the flu season. So if you see a few elderly people come down with influenza in the middle of the flu, with an influenza-like illness in the middle of the flu season, you think it's influenza. And it wasn't really until you got this cluster of cases around the seafood market that people started saying, hey, I think there's something different going on. So this was reported to the WHO on the 31st of December, 2019. And what is absolutely incredible is on the 10th of January, so 31st of December to the 10th of January, we had the full genome sequence of this virus. And we could definitively say that it's a coronavirus. That's 10 days from notification to full genome sequence. I mean, that's just absolutely incredible. Now, this genome sequence was a really, really powerful tool because it allowed us to compare this virus to other coronaviruses that we knew about. So this is basically just a graph showing you how similar this new coronavirus is to other coronaviruses that are out there. So if this virus was identical, what you would see is it would be a straight line at the top. So you can see that this virus most closely matches the virus shown in blue, although it's not a 100% match. And just to give you a contrast, the virus shown in red here is the original SARS outbreak that happened in the early 2000s. So you can see it's related, but it's quite different. And so you might be asking, okay, well, what is this virus here in blue? And this virus here in blue is actually a bat coronavirus that was also isolated in China, but a few years before, and in a different part of China. So it's not identical, but it's suggestive enough that this is really telling us it's probably a spillover event at some point from bats. So this virus has spilled over from bats into humans and caused problems. And this raises the question of how and when did this happen? Look, we don't know, is the short answer. Early on in the pandemic, there was a lot of suggestions that this all happened at the seafood market because there was a lot of different animal species there, and probably a bat infected an intermediate species, and a lot of different intermediate species have been probably unfairly implicated. Initially it was snakes, then it was tortoises, then the port pangolin. We don't really know if there was an intermediate host. It probably didn't happen at the seafood market. All we know at the moment is that this virus likely derived from bats and then at some point made its way into humans. And this point of origin is still really an area of active investigation. So what about the 1918 influenza virus? Where did this pandemic start? And much like SARS-CoV-2, we don't really know the definitive answer. There's sort of three competing theories. One is that it started either in the UK or France, somewhere along on the fields of World War. One that it started in Shaanxi province in China. This has largely been debunked. And probably the most convincing evidence is that it actually started in Kansas in the USA, and that eventually this virus spread to Europe via the movement of troops for World War I. But where did this virus, this 1918 flu virus, come from? Well, again, and I don't want this to be the theme of the talk, but we don't actually know. So really there's sort of two options of how this virus spilled over into humans. The first is that it was an avian virus and it directly spilled over into humans. So it was a virus evolved in birds, and some unfortunate human became infected. And because their immune system had never seen it before, they were highly susceptible to disease, and then they could then transmit it to another individual. The second option is that maybe what happened is you had this process of reassortment. And this can happen with influenza, and it's one of the sort of, as a virologist, I think cool, but probably from a public health perspective, bad things about influenza, is that this virus, if two influenza viruses co-infect the same cell, what they can do is mix and match their genetic material. And this can create a new virus. And because this is a new virus, once again, our immune systems have never seen it before. So then we're susceptible to infection and it can cause a pandemic. The reality is we don't know which, if either of these scenarios is true. There's evidence for and against both. And there's even some suggestions that maybe it was this direct spillover event, but it didn't come from birds. So we don't really know. But what I want to emphasize to you here is the commonality of these two beginnings of the pandemic. And these two pandemics really began when an animal virus crossed over into the human population. So this really speaks to the strength of an idea that has been emerging in infectious disease. Probably it's been around for about the last 10 years, but now people are really starting to believe it, is this idea of One Health. And it's the idea that human health, animal health, and environmental health are all incredibly interconnected. So if you're concerned about human health, you should also be involved in dialogues and discussions with animal health and environmental health, because really any one of these can affect any of the others. And I think this is one of the big lessons that we're learning from this pandemic, that clinicians need to talk to vets, who need to talk to public health people, who, and it's about this comprehensive response. So that's sort of lesson one we can take away from this historical comparison. I think lesson two is really about the public response. And even though these were 100 years apart, it was incredibly similar. So there was initially a lot of denial. Now, when we talk about Spanish flu, we've got to take this in the context of this was around World War I. So, of course, any government doesn't want to create fear. They don't want to create uncertainty more so than already exists in a time of war. So, there was a lot of news going around saying, the well-nourished don't need to fear the Spanish grip or the Spanish influenza, or, this is really a problem. If you look at the sort of allied documents, this is really a problem for the enemy. We don't have that issue. And in fact, we see very similar things emerging and during the COVID-19 pandemic. So we had Brazil, Bolsonaro, who was really shrugging off the coronavirus pandemic, saying that it was not a big deal, whilst the case and the death toll in Brazil continue to increase. And we have this incredible tweet from Donald Trump on the 24th of February saying that the coronavirus is very much under control in the USA. We're in contact with everyone in all relevant countries. CDC and World Health Organization have been working very hard and very smart. Stock market starting to look very good to me. So I think initially for a lot of people, it's very hard to accept the reality of a pandemic. And that's perhaps just human nature. It's hard to accept the change and the potential uncertainty that comes with it. Following denial, whether it's 1918 or 2020, there is panic. Now, the modern form of panic in 2020 seemed to be buying toilet paper for whatever reason that I still don't understand. But you see reports of this in 1918, and this is just one particular article where there was a response from a police officer who was so desperate for an individual to wear a face mask because they were so concerned about the pandemic that they actually shot them. The individual ended up in hospital where they were not necessarily worried about medical care, but a face mask was promptly placed upon them. So there is definitely, and again, it's a natural human response when there is panic to something that is unknown. And then the third sort of commonality we see in the public response is really what I'd like to call creative treatment options. So in 1918, they didn't actually know that the pandemic was caused by a virus, yet alone by influenza virus. They had no idea. They knew it was a respiratory infection, but that was it. So that meant there was all sorts of strategies to try and control the disease. So people were using whiskey, whether or not that just made you drunk and feel better about things, I don't know. There was inhalation of various substances, and in fact, zinc inhalation was very popular in New Zealand for some reason. There were these devices that you could use to breathe through that somehow cleaned the air and made it safe for you to breathe. And then there was also individuals who were walking around with sort of various things tied around their neck, various spices, various smelling substances in little bags that could potentially protect them against influenza. Now, I think it's very easy in 2020 to laugh at things and say how ridiculous, you know, of course, whiskey won't protect you against influenza, or nor will some smelling potpourri. But I would argue that 2020 is not much better. So we have a lot of creative treatment options that have emerged, again, probably out of this panic response. There was this famous story of Pete Evans advocating a machine to clean the air of COVID. There was so much suggestion that drinking water could actually flush out the virus that the WHO had to put out an infographic on it saying that that's not the case. And of course, there was the tragic case in the US where an elderly couple heard about the potential beneficial effects of hydroxychloroquine, saw that their aquarium cleaner contained hydroxychloroquine, and when they got a cold, they actually drank their aquarium cleaner thinking that it was going to save them, and unfortunately it cost one of the men his life. So whilst it is very easy to judge, I think in times of desperation, we as humans reach to whatever we can, and whether it's some old-fashioned thing tying around our neck or a newfangled device, there are unfortunately susceptibilities to that in the population. So let's look a little bit more about, in both pandemics, what is or was saving lives. And what's incredible is that the strategies that worked in 1918 are largely the strategies that are working today. So the first thing is hygiene. This was something that was advocated. People knew that this was a respiratory disease. They didn't really get a sense of how exactly it spread, but they knew that probably the best advice you could have was wash your hands every time you come home, wash your hands before you eat, wash your hands. And in fact, this has been a big part of the public health campaign today, that really just taking account for personal hygiene, being careful how we open doors, washing our hands when we enter the house, learning not to touch our faces in public. This has been incredibly effective. Another sort of concept that dates back to the 1918 pandemic is this notion of social distancing or physical distancing. And in the 1918 pandemic, lots of public events were closed. There was a lot of resistance to closing some things like churches and funerals, but in fact, they had to close. Schools were closed. There was stories of in New York, when schools were reopened, they had to be outdoors because, again, they had a sense that this pathogen didn't spread outdoors as much. So there's these incredible analogies between what worked. And I think for some people, they find that very concerning, that 100 years later, we're still relying on the same public health advice. But actually, to me, all it just says is that this works. This works 100 years ago, this works today. Social distancing, hygiene, it all makes a very big difference. Now, face masks is one of the controversial issues that has emerged during the COVID-19 pandemic. And in fact, it was quite controversial in 1918. Some people really thought that face masks were the answer. And this great quote from the chief of San Francisco's Board of Health saying that once everyone in the city wears a mask, influenza will be under control in a week. Unfortunately, that did not come to fruition. And even though masks, we'll discuss a little bit about their efficacy, the problem in 1918 was that they were either really poorly worn, so they were just made out of thin cloth, or sporadically worn, or people would wear them much like you see today, where people were walking around with masks on their chin. So as a result, there wasn't really a significant difference in areas that had voluntary mask wearing and mask wearing that was enforced by law in terms of the mortality rate. Now we fast forward to the COVID-19 pandemic, and our understanding of masks has become maybe more political, but also more nuanced. So when we talk about masks, there's two different types of masks. Now we have these respirator masks. and we have the surgical masks. So I'm really just going to talk about the surgical masks and the widespread use of the surgical masks. And I think a lot of people have a lot of problems with the recommendation of masking because the messaging around this has changed during the course of the pandemic. Initially, a lot of the public health messaging was don't wear masks. That's because we need them for the healthcare professionals and we need to save them. And that's true, but it also reflected our understanding of how the virus was transmitted. So these surgical masks are really, really good to stop you infecting other individuals if you're infected. They may provide some protection from you getting the virus, but they're really about protecting other individuals. Now, early during the pandemic, we thought that this virus was only transmissible once you had symptoms. So then it made sense that if you had symptoms, you didn't really need to wear a mask because you should be at home and you shouldn't be out and about in the public. But then there was slowly more and more evidence of individuals who were asymptomatic spreading the virus. And there's been a broad range of percentages who are asymptomatic identified as spreading this virus. And this ranges from anywhere from 10% to maybe up to 60%. And probably that range reflects the fact that sometimes an individual is asymptomatic and spreading the virus because they've yet to develop symptoms. And that individual is not really considered asymptomatic, they're better considered pre-symptomatic. Or that individual is a true asymptomatic and they have the virus, they're infectious, and they never ever develop any signs of disease. So probably those true asymptomatic individuals are maybe about 20% of infected individuals. But you can imagine if there's mandatory mask wearing, that means that you are stopping the transmission from that 20% who are walking around not realizing that they're infected. So that's a big reason why the messaging around masking has changed. And I think that's something that needs to be clearer to the general public, that our understanding of viral transmission has changed. And so too does our public health advice have to change to reflect that. So the other really interesting contrast with the 1918 pandemic is really who is or was the most vulnerable. And I have elderly parents, like many people out there, and I often tell my parents, well, look, it's just unfortunate that you're living through this pandemic because you're just living through the wrong pandemic. So we know in the COVID-19 pandemic, if you're elderly, it's a big risk factor. So, you know, if you're above 80, the mortality risk jumps up to about 15%. And in countries where the virus gets into care homes, this was particularly the case in Canada, but Melbourne is another example of this, it pushes the mortality right up because you have all these individuals who are high risk, living in high density conditions. Flip back to the 1918 pandemic, and it was a much better time to be elderly. So actually, normally flu is very much a disease of the very old and the very young. But in 1918, the very old did quite well. And it's thought that this was because they were protected from a flu strain that had circulated prior to 1889 and that they had some cross-protective immunity. The people who were most at risk are people in my age group who are in these sort of middle years of life. So again, as much as it doesn't help my parents, I just tell them that they should have been living in 1918 instead of 2019. And this is just one of the major differences between the two pandemics. But I just want to end by reminding you why we're in such a better position in 2020 than we were in 1918. So when we talk about the 1918 influenza pandemic, this is when it happened, 1918, no surprises there. And as I mentioned to you, influenza as a virus hadn't even been discovered then. So influenza virus was not discovered until 1933. So how on earth do you fight a pandemic when you don't even know what was causing it? Then when we look when the first influenza vaccine was developed, it was not until the 1940s. So you had this lag of about 20 years between the pandemic and actually developing a vaccine to the virus, 20 years. Fast forward to now, and if we say the virus was discovered, for argument's sake, at the start of 2020, we are now in October 2020, and we have 10 vaccines, I think maybe more than 10 now, that are in stage 3 clinical trials. These are the final clinical trials. So this is actually a little bit out of date, but there's multiple vaccines that are being trialed across a large number of people. We're talking up to 10,000 people. And this is the final stage of licensing a vaccine. So we have gone from 20 years to about 10 months. That is an incredible achievement. And that's really what gives me hope getting through this pandemic, that because of all the scientific advances we have made, we are now in a much better position to fight the virus. The other thing that's been really incredible during this pandemic, that again was not the case in 1918, was the surge of knowledge that we've had. And this just gives you an idea of how many journal articles were published on SARS-CoV-2 or COVID-19 between, say, February and March. So we go from basically nothing to all of a sudden about 300, and then the preprints, these are not peer-reviewed, but they're put online for people to read and learn from, was about 600. And this is in the thousands upon thousands upon thousands. I dedicate probably at least an hour of my day every day catching up on what's happened overnight, literally overnight, in the COVID-19 research field. So this has been an incredible, unprecedented rate of growth. And as a result, probably that feeds into the vaccine design and our therapeutics and the lowering mortality that we've seemed to have achieved. The flip side of that is there has been a lot of misinformation, and this is a uniquely modern challenge that we have in this pandemic. And there's been some quite dubious articles published, and there's been some quite significant retractions. Probably the most notorious of which was the retraction about this hydroxychloroquine study, which still remains quite controversial. So there are downsides to this knowledge increase, but essentially because of the scientific skills that we have and the technology that we have, we were able to get a very, very rapid understanding of this virus, how it causes disease, and how we can treat patients. The final thing that I think is often overlooked is diagnostics. And this has played an essential role in this pandemic. Now imagine in 1918, you had no idea what pathogen was causing the pandemic. So how do you diagnose people? How do you know who's infected and who's not? Here we had a rapid diagnostics rapidly developed upon sequencing the genome, and we had testing implemented. Some countries like Australia have done much better in our testing than other countries, and it really seems to be this association between countries that have done very well in implementing efficient testing with those who've had a very effective COVID-19 response. And now we're getting to the point where we're talking about point of care rapid testing, where you could be distributing cheap tests to individuals that they could administer at home under 5 minutes. And this might be the deciding factor of whether or not they go into work that day. And this is probably one of the ways we can almost test our way out of this pandemic, short of a vaccine or effective therapeutics. So we've really come a long way. And I know it doesn't feel like it. And I know some of the things that we're doing are very reminiscent of 1918, but the reason for that is that it works. So I guess the thoughts I want to leave you with is that viral pandemics are part of our past, they're present, our present, and our future. I know that in my lifetime, this is not the last pandemic I'm going to experience, but what I hope is that this will be the worst pandemic that I will experience. And what I hope is that we really do learn from this, and we learn from this that we learn to prevent future outbreaks by investing in disease surveillance. So across a wide variety of different animals, we invest in basic science. So we have an understanding of how to rapidly develop therapeutics, vaccines, how viruses infect and cause disease. We understand the importance of international cooperation, because the reality is this pandemic won't be over until every country has dealt with it. We cannot say, okay, Australia has very low numbers, therefore the pandemic is over for us, because we are part of an interconnected world. So this needs international cooperation. And finally, what I hope this pandemic has taught us, and I think it has really by talking to people, is about literacy and public literacy about science and understanding how science works, understanding why public health measures are important, understanding what measures to adopt in our day-to-day life to stop disease spread. And I think if we can take away these lessons from this pandemic, that this pandemic, although it's been a terrible event for many, many people, and it's been disruptive to all of our lives, it may have actually served a very good purpose in preventing the next and potentially worst pandemic. Thank you very much.
Thank you, Kirsty, for a both inspiring and a tiny bit terrifying presentation. Now, I've already got a few questions coming in. If you would like to ask questions of Kirsty, please put them in the Q&A box in the bottom right of your Zoom screen, or wherever it might be on your particular app, and we will get through as many of those as we can in the time left. Don't forget, if you would like to see more BrisScience talks, you can head to our website and sign up to our mailing list, or Facebook or Twitter, all the many media, and you can be notified of our next talks. Next talk will be in November on the 9th, Monday the 9th, and details of that talk will be coming very soon. Okay, let's go to a couple of questions. We have a question here from Mundayan, who asks, so what caused the 1918 pandemic to peter out, given that no vaccine was developed?
Really excellent question. And this is one of the things I think is absolutely fascinating about flu. So what happened with the 1918 pandemic virus is it kept on going, and eventually you did get some level of herd immunity. Now, the virus never actually disappeared. The 1918 virus kept kicking around in the human population until 1957. But it wasn't kicking around as a pandemic anymore. It just became part of the seasonal flu strains that people saw every year. And the reason for that is because the surviving population developed enough immunity to it that it was no longer this terrible new unseen virus to their immune system. Now, having said that, that herd immunity strategy cost, say, 50 million people their lives. So this is not a strategy you want to bank on. But in the absence of any understanding of virology, diagnostics, vaccines, that's really what people had in their arsenal.
Right. We have another question here, which is, why would some viruses affect middle-aged people more than young or old?
Yeah, excellent point. And this is something I didn't touch on, but this was one of that really key feature of the 1918 pandemic, that people in the middle years of life did a lot worse. And there's still a lot of theories about this. Probably the best understanding of this is that a lot of the disease in the 1918 pandemic was driven by sort of this overexpression of the immune response, a really, really robust, rapid immune response. Exactly what you want normally in terms of fighting a virus, but in this case, it was completely out of control. So it was thought that individuals who had the best immune response, or the individuals who had the strongest immune response, actually also had the worst reactions to the virus. And we still don't fully understand this because, as you can imagine, the amount of material available to study the 1918 virus is quite limited, but that's really the theory as to why those individuals suffered disproportionately. And again, I would say that the elderly, who would also normally suffer because their immune response is at the other end, where there's basically not much of an immune response, this time they had that pre-existing immunity that protected them a little bit.
Interesting. And this perhaps leads a little into a question from Harold here, which asks, why such a spread of symptoms? Some people die, others have no symptoms. Don't know if you can share anything about why we have that.
This is one of the big mysteries, and this is what people are working on. So I in fact read a paper today about this that has just been printed. So you're right on the money in terms of topical areas. There are some genetic factors that have been identified. So some people just have certain mutations that leave them more or less susceptible to viral infections. We know that underlying diseases play a big role. And in fact, that's one of our areas of active research, why people with obesity and or diabetes do much worse. And that seems to be because those underlying metabolic conditions really alter your immune response, and particularly your antiviral immune response. Age is another big factor. And one of the things that we're also investigating is, why do kids do better and why do the elderly do very poorly? And again, we think that relates back to differences in how their immune system's skewed. But this is still an area of ongoing research. And as you can rightly imagine, if we can understand why some people just have a really mild disease and work out a way to sort of therapeutically induce that, we would be in a much better position. So that's what we're working on.
All right, great. Let's jump to another range of questions around vaccines and resistance. We have a question from Fiona here. Any thoughts on durability of resistance and hence efficacy of vaccines? I'm assuming this is mainly about the current COVID.
Yeah, so look, the short answer, again, a theme of this talk, we don't know. And again, this is something that we're actively doing. We've just been given funding by the Australian government to actively track how long people remain immune or have an immune response to COVID-19 once they've recovered. The reality is sometimes immunity wanes and sometimes it doesn't. And it's different for every virus. So we don't know for COVID-19. The good news is that even if immunity to a natural infection wanes after a period of time, that does not necessarily mean that immunity to that vaccine will wane. Because a vaccine, because of how vaccines are designed and how they can actually, it's a very intelligent design, they can sometimes induce a better immune response than the actual infection itself. So the short answer, we don't know how long natural immunity to COVID-19 lasts, but even if it wanes, it doesn't mean that a vaccine won't be long-term protective, because there are things we can change in the vaccine that we can't change about a natural infection.
Great. Now, you touched on masks in your talk, Mickey, surgical masks and their impact. So we have a question which I guess gets to, would you recommend that we all wear masks when the virus is still going around?
Yeah, it's a difficult question.
At the risk of putting you in making medical advice here.
Look, I think this depends on a lot of things. So the first thing is, when you say the virus still going around, how much is it going around? So in areas where there is a lot of community transmission, I would certainly recommend wearing masks, because that's just one extra thing that you can do to stop the transmission of the virus. In areas like Queensland, where there's not really much community transmission, or if any community transmission, I feel comfortable going around without a mask because the risk isn't high. Now, this then becomes a question also of what type of mask and how to wear the mask. So if you're talking about wearing a mask, this is not, you see some of those horrible social media posts of people wearing mesh masks or something like that. This is about effective masks. You can wear cloth masks, but there are certain regulations they need to follow. It's about being 3-ply. It's about wearing it over your nose, over your mouth. When you put on the mask, you know, you're not touching the actual mask, because if you imagine that there's virus there, you don't want to touch the mask, take it off, and then wipe your nose. So there's certain things that we need to employ to make masks effective. So yes, in areas where you can't socially distance and when there's community spread, masking is effective. But again, because right now I'm living in an area where there is, touch wood, no community transmission, I'm comfortable going around without a mask.
Great. You got energy for a couple more questions?
Yeah, sure.
We've got a bunch here. So this one, got a question from KJ. We sometimes hear about viral load in the news. Has it been determined for certain that viral load is affecting the illness death rates currently, or might have been a factor in 1918?
Yeah, this is a great question, and this is something that's even debated amongst scientists as to whether the amount of virus that you're exposed to then goes on to determine the clinical course of your illness. I would personally say it's probably more of a threshold issue. There will be a threshold that you need to get infected. So if you fall below that, let's say that, and we don't know this for COVID-19, but let's say the threshold is 200 little virus particles. If you're exposed to 100 virus particles, then probably it's not enough to establish infection, and your immune response quickly clears it and you don't get an infection. If you're exposed to 300 particles versus 400 particles, I don't think that's going to make a difference. You're going to get infected. If you're exposed to 400 particles versus 10 to the 6 particles, I don't know what you're doing being exposed 10 to the 6 particles, but let's just imagine, that may make a difference because it may accelerate the course of the illness. So there's nuances to this. But I think really the most important thing is whether you get infected or not, because ultimately what determines the outcome of infection, maybe viral load plays a role, but really I would say the factors that are more significant are things like age, your sex, your underlying conditions, your general health status, and all of those things are going to be different.
Great. question here, which this is one that I personally find quite disturbing, which is Paola about what do we know about the long-term health effects of COVID-19?
Yeah, this is an excellent question and something that we're also actively studying. So I should use this as a chance to recruit people to our study. So what we know is that there are long-term consequences. These long-term consequences have a broad range of clinical presentations. They can be anything from cardiovascular disease, neurological disease, simply feeling tired, struggling to recover from exercise, a general fogginess, periodic fevers. All of these things have been described in people who've recovered from COVID. What's concerning, and we study the cardiovascular long-term effects of this, what's concerning is that there was a study out of Germany that showed of 100 people that had COVID, about 80% 2 to 3 months after had some sort of cardiovascular abnormality. And most of these individuals had what we consider to be mild COVID, insofar as they never had to go to the hospital. They could recover at home. So to me, one of the things we're trying to understand is who is most susceptible to these long-term effects and how long-term are they? Because are they going to last for 2 months? Are they going to last for 8 months? Are they going to last for 8 years? We don't know. But I think what we should take from this at the moment is the knowledge that if you can avoid it, avoid getting this virus. Because it's not just about whether or not you have an asymptomatic or infection, or whether you closely relate to an elderly person who you may then infect. It's also about the fact that long-term, you don't know what this will do. And there's been some pretty bad studies of athletes who've been infected with COVID-19, and this has significantly affected essentially their careers because they're already performing at the top, physical level that they can, and COVID-19 has interfered with that. So we don't know. We're monitoring it, and lots of groups are monitoring it and investigating it. And I suspect in 6 months, we'll have a better understanding. But in the interim, use it as a motivation to where you can avoid being infected.
Yeah, really important message for people not to get just distracted by those 0.4, 0.6% fatality rate figures. And we're almost at time, but just have a couple of questions to finish. One is, well, I'll ask these two together. Yumi asks, what role do you think social media played or is playing in this pandemic? And Don, who says amazing talk, asks, I'm not saying this is a leading question, but what is the best resource to inform people who have questions or have doubts about the science/reality of this pandemic?
Yeah, and there's sort of been an infodemic of misinformation throughout this pandemic. And social media has played a big role in that, because what you have is people who are not necessarily medically trained, who are going on to give advice about something that they don't actually know much about. And sometimes this advice can be very harmful. This has been one of the downsides of social media. One of the incredible upsides that we don't talk about it is actually it's been an incredible way as a scientist to communicate. Through social media, I'm able to directly communicate with other scientists around the world. I'm able to directly communicate with clinicians. Other clinicians are able to communicate and share their experiences. So there's some pros and cons of social media. I think what you allude to really in the second part of this question about how do we fight this misinformation, I think that comes down to each one of us individually. This is a big reason why I do science communication. I'm busy in the lab. My skills actually lie in the lab and not in talking to the general public. That's not what I'm trained in, believe it or not.
I don't.
But this is really our responsibility. It's for every individual who is well informed, who has read the right, accurate scientific information. And by this, I mean that which is peer reviewed, that which is provided by the WHO, that which is provided by universities, and not that which is just a meme on Facebook, to then go out and talk to their family and say, hey, I know you have some concerns about the vaccine, but look, this is the scientific information that says any vaccine that's administered will be tested and will be safe. So I think really fighting the misinformation comes down to each and every one of us, and just attending events like this already tells me that you're one of those people who can distribute the information correctly.
That is a rousing call to arms. So I have one final question for you, which is hypothetical. Your lab at UQ receives an anonymous $100 million grant, or insert large number here. What's your big plans? What's on your wish list? What would you do next?
So a lot of our work is about pandemic preparedness. And prior to this pandemic, not many people were interested in pandemic preparedness. And suddenly there's been a boom in interest. So one of the big things that we're really interested in is developing drugs that we can actually use to target multiple different viruses, so that whatever the next pandemic is, we have something stockpiled ready to treat patients. And the way in which we can do this is actually using drugs that target the bad components of our host inflammatory response. The components of our host inflammatory response that with these pathogenic viruses, they go insane and they cause all the damage in our body. So if we had all this money, it would be invested into that, and it would be invested into developing these sort of preclinical studies that we have into actually clinical therapeutics that could then be stockpiled and ensured that no matter what the next pandemic came along, we would have at least something on hand on day one to treat patients.
Well, that is, I very much hope that one of our viewers happens to have a very large checkbook and would like to make these dreams happen. But we really thank you for your time tonight, Kirsty. It was a great insight into the evolving state of play and the research that you're really at the cutting edge of. And I think, as I mentioned at the start, everybody, you know, not just great scientists, but brilliant communicators. And Kirsty, you absolutely fill that bill. So thank you so much for your time this evening.
Thank you, my pleasure.
And everybody, if you'd like to, after you log off, stay on for just a couple of seconds and there'll be a little survey for you as well. So thank you so much and have a great night.
Thank you. Good night.